for the opportunity to be part of the panel here today. So I'm going to start with a quick poll. If you're raising a child in a malarious region of sub-Saharan Africa, how many of you would be interested in providing your child with a tool that's now been shown to reduce overall mortality by 15%? Quite a few of you. Maybe some of you aren't parents. But those are the sort of data that we're seeing now from the early implementation of the malaria vaccine in sub-Saharan Africa. And as you know, the vaccines are starting to get rolled out. There's really unprecedented demand in terms of vaccines that we've seen in the other vaccines that we've worked on, really unprecedented demand, and we expect 16 countries to introduce the vaccines by the end of the year, and about 30 or so in total are showing interest. So really huge demand. First significant new intervention recommended by WHO in over a decade. So really an exciting time. But I think, as you've heard from other speakers, this is not a silver bullet. This is another tool, another imperfect tool, which actually gave relatively modest efficacy in clinical studies. But in real-world settings, now we're getting the real data, another tool that has potential to be very impactful, despite those modest data from clinical studies. And I want to talk a little bit about that because, when we develop vaccines and we introduce them, we typically do that with limited data. We have phase 3 studies that are very controlled conditions, sort of artificial. No child should die from malaria, especially in a controlled setting. Yet when we roll the vaccines out in these real-world settings, we're seeing really quite impactful results. So there's still a lot we can learn. I think that's really a key point. We don't know everything about these vaccines. We still don't know how to best use them. We're still learning. And I want to give you 3 examples of how we're learning and new data that will be coming over the coming years, which really will continue to help us to maximize the impact from this new innovation. So the first one is around seasonal vaccination. So we know these vaccines have relatively high-level short durability. And what happens if we implement the vaccines just before the rainy season, when children are most at risk? Well, those studies have been done, and we have data now that extends over 5 years that shows that actually, if you implement the vaccines just before the peak period of risk, you can actually increase the efficacy by about 50%, up from about 50 to about 75% efficacy, which is quite significant. Challenge being, that's a difficult schedule to implement. So we're not seeing any of the countries so far actually implement the vaccine using those schedules, despite the fact that we can improve efficacy by 50% in the short term. So these are important lessons in terms of implementation. Second one, another key challenge of the vaccine is it requires 4 doses, and the 4th dose in the second year of life. Vaccinating children in the second year of life is challenging. And so we're going to have data over the coming months which will tell us how important is that 4th dose. Do we really need that 4th dose? And if it's proven that it's not essential, then that again could ease implementation by really condensing everything into the first year of life, which would be very advantageous. And then the third point I wanted to make is really around the power of the EPI platform, the immunization platforms which were established 50 years ago and have been responsible for preventing the deaths of over 100 million children over the last 50 years. It's really a remarkable platform, and really one of the key assets of vaccines is we have this amazing delivery platform so that with new tools, we can get to quite high levels of coverage quite quickly. So there are ongoing studies to look at the ability to leverage those contacts with the delivery of other interventions. We know that we can deliver bed nets through those contact points when children get vaccinated. There's going to be data coming over the coming years on perennial malaria chemoprevention. What about if we give those low-cost drugs at the same time as the vaccine so that we can provide some protection to those children while their vaccine-induced immunity is building through those multiple doses. So these are the types of learnings that we still have, and we're continuing to figure out how to best use the new tool in the context of the other tools and leveraging the immunization platform. My final few seconds, I just want to make a few points on next generation vaccines. We need to continue to innovate. So 2 things we need to do. We need to continue to make sure that these vaccines are going to be scaled up and available to all children that need them. We might need 100 million doses or more of these vaccines over the next 10 years or so. So huge demand. This is going to be expensive, and obviously cannot come at the cost of the other tools that have proven to be highly beneficial over the last several decades. But we need to continue to innovate. We need new tools. We need better disease reduction vaccines that can provide better clinical benefit against disease and death, and ultimately strive for vaccines that can break the cycle of transmission and can work in all age groups, that can ultimately help accelerate elimination and eradication efforts. So as a parent of children who've made it through their teenage years without the fear of dying from malaria, I really hope that we'll see those investments over the coming years to both ensure availability and access to these great new tools that we have, but not at the cost of the tools that we're already using, and then also continue to innovate future vaccines, reduce the burden of death down to zero, and eventually our shared goal of accelerating elimination and eradication. Thank you.